Well, happy Friday, everyone, and welcome to Friday Palliative Care Chalk Talk. My name is Patrice Vidal. I am your moderator for today. I have the honor of introducing three guests here today to talk to us about buprenorphine and some of its lesser known uses. So I'll start in no particular order with Dr. Leanne Jackson. Is an assistant professor in the section of geriatrics and palliative medicine at the Michael E. DeBacke VA Medical Center, where she directs the outpatient palliative care clinic. She is a clinician educator at Baylor College of Medicine. Dr. Jackson received her undergraduate degree from the University of Texas at Austin and completed medical school at Vanderbilt University in Nashville, Tennessee. She completed two fellowships at Vanderbilt, first in oncology and then in hospice and palliative medicine. She has written two children's books and is working on the third. Dr. Mary Garcia is currently a full-time palliative medicine physician at Michael E. DeBacke Veterans Affairs Medical Center and serves as assistant professor at Baylor College of Medicine. She obtained her undergraduate degree from the University of Philippines and her Doctor of Medicine from University of Santo Tomas Faculty of Medicine and Surgery. She completed two fellowships as well, geriatric medicine at Baylor College of Medicine and hospice and palliative medicine at MD Anderson. Her interesting fun fact is she hates paying full price. Woman of my heart. And Dr. Ivy Poon is a professor at Texas Southern University. Previously had a practice at the site of at Michael E. DeBacke VA Medical Center, Geriatric Clinic, and recently started her site in pain and palliative care at Houston Methodist Hospital at Texas Medical Center. She received her Doctor of Pharmacy degree from University of Houston, pharmacy residency at the Memorial Hermann Healthcare System. She obtained her master's degree in palliative care from University of Maryland at Baltimore. She likes to knit and constantly has knitting projects going. So welcome, ladies. I'm so happy to have you here, and the floor is yours.
Thank you so much for having us. So for the last 2 years at AHPM, it seemed like buprenorphine has been a really hot topic, and we are excited to share our perspective today. We don't have any disclosures. In May, our review paper on buprenorphine for analgesia in palliative care was published in the Journal of Pharmacy, but we won't be focusing on pain today since there is another amazing presentation in this series by Dr. Janet Ho and Dr. Katie Fitzgerald-Jones, and we encourage you to watch that one as a complement to our presentation. Because Chalk Talk is aimed at sparking further interest in the subject, we wanted to explore other benefits of buprenorphine beyond pain, and we hope we can inspire you all to do some further research in this area. Our objectives are to briefly review the pharmacology of buprenorphine because it's essential to understand what makes buprenorphine unique, and then we're going to share our thoughts on special populations within palliative care and uses outside of pain.
Good morning, everyone. I'm going to spend the next couple of slides talking about the background information for buprenorphine. Buprenorphine is a Schedule III agent. It is a category of agent that is associated with low to moderate potential for physical and psychological dependency. In January of 2023, the DEA removed the X waiver that used to be required for treatment for patients for opioid use disorder. Though even before that, we could use buprenorphine for pain without the waiver. Despite of all the misconception and a lot of stigma against the use of buprenorphine, there is some false belief that causes preventing us as a provider to prescribe it. And some examples are thinking that buprenorphine as a partial opioid agonist implies that it has partial analgesia effects, and that the ceiling effects for respiratory depression that I'll discuss later apply to pain control too. Lack of awareness and strategies to rotate from full opioid agonist and stigma of buprenorphine use as a treatment for opioid use disorder may also prevent use of buprenorphine. Buprenorphine is a semi-synthetic, long-acting partial agonist at the mu-opioid receptor site. It has a high binding affinity at mu-opioid receptor. It has a high potency and slow dissociation rate, allowing for effective and long-lasting analgesia effects at low dose. The label partial agonist is based on the level of mu opioid receptor G protein activation compared to other opioids, but it should not be misinterpreted as partial analgesia. Buprenorphine has been shown to be as efficacious or more efficacious than morphine in producing analgesia. As a partial agonist, buprenorphine has lower mu opioid receptor signaling than full mu opioid receptors, which contribute to the fewer side effects profile. It also lower potential for withdrawal if those are missed. After buprenorphine binds to mu opioid receptor, there are two pathways, the G protein analgesia pathway and the beta-arrestin pathway. Buprenorphine activates G protein via the mu phosphorylation, just like other traditional opioid, but it has less beta-arrestin activation. Less beta-arrestin signaling means less constipation, less respiratory depression, less physical dependency, tolerance, and less mu opioid receptor internalization and downregulation. Buprenorphine is an inverse agonist at the kappa receptor, which may lessen anxiety, depression, suicidal tendency, stress-like effects, and opioid craving. Additionally, combined with less beta-arrestin effects, we see less hyperalgesia effects with buprenorphine. In addition to the partial mu opioid receptor effects, buprenorphine is a full agonist at the opioid receptor-like ORL1 receptor and antagonist at the delta receptor, which both results in decreased tolerance, reward. Buprenorphine preferably acts on the spinal receptor rather than the brain sites, and this reduces euphoria. Pharmacokinetic-wise, buprenorphine is highly protein-bound to alpha and beta globulin up to 96%. It is extensively metabolized hepatically via the cytochrome P3A4 pathway to an active metabolite norbuprenorphine. It can be used in mild to moderate renal and hepatic impairment. There is a lack of evidence for using very severe renal impairment, so use that in caution. And also in severe hepatic impairment, we will need to have dose adjust.
Okay, everyone, take a screenshot. This is the table that I have printed out and taped up on the wall in my office. We're just about to talk about dyspnea management, so I want to draw your attention to the fact that 5 micrograms of transdermal buprenorphine is equivalent to approximately 12 milligrams of oral morphine per day. Right? So here we go. Buprenorphine for use in dyspnea and rhinorrhea. Refractory dyspnea is the most common symptom in end-stage pulmonary disease. 94% of end-stage COPD patients experience breathlessness in their last year of life, and 76% of them find it very distressing. Opioids have been a mainstay of dyspnea treatment. Prevalence of other airway symptoms in end-stage pulmonary disease is really not well documented, nor do we do a good job of assessing it. In studies, 88% of end-stage pulmonary disease patients experience at least one nasal symptom most days of the week, with the most common being rhinorrhea in 52% of patients. At AAHPM this year, I presented a case series of 7 end-stage pulmonary disease patients from my clinic who were treated with buprenorphine for dyspnea, with a surprising positive impact on rhinorrhea. We don't have time to present all that data today, but I do want to describe why we think end-stage pulmonary disease patients are the ideal population to treat with buprenorphine. This is beyond buprenorphine's favorable side effect profile compared to the full mu opioid receptor agonists. And that includes, as you just heard, less respiratory depression, less sedation, and less constipation. So in that case series, 6 out of 7 patients were treated with 5 microgram weekly patches, and 1 patient who ultimately got colon cancer went up to 15 micrograms. All of the patients had completed pulmonary rehab prior to starting opioids for dyspnea. 3 of the patients had really severe rhinorrhea, and all 3 had resolution of their rhinorrhea. I will add that it's really hard to assess dyspnea through questionnaires. It can underestimate the impact of treatment because patients might increase their activity level to reach their previous breathlessness severity level if that treatment is helpful. We do hope that today's Chalk Talk sparks some interest in the area, because when we did a literature review back in March, there were no studies that described buprenorphine for the treatment of rhinorrhea, and there were only 2 studies for dyspnea. One of them looked at high-dose sublingual or buccal buprenorphine for dyspnea, and the other was actually the opposite. It was a case report that noted that methadone did better for buprenorphine for interstitial lung disease, cough, and dyspnea. Though I will say, dyspnea for interstitial lung disease is not the same as dyspnea in COPD. And as was noted in this 2020 randomized controlled trial, morphine was not found to be effective for dyspnea in interstitial lung disease, so kind of a different beast. The rationale for using buprenorphine is that there are shared areas in the brain that process both pain and breathlessness. Opioids appear to modulate anticipatory breathlessness and the sensation of air hunger for some patients. There is level 1A evidence that supports using low-dose opioids for breathlessness, and the best evidence is actually for less than 30 milligrams a day of sustained release oral morphine. However, common side effects to that are constipation. And constipation can exacerbate dyspnea because you get this extrinsic upward pressure of full bowels pressing against the diaphragm, and it decreases lung height. So let's imagine together our typical end-stage pulmonary disease patient. You're thinking of an elderly patient with COPD. They've probably also got sleep apnea, and they're likely going to need prolonged opioid therapy for their dyspnea, since on average these patients live 2 to 4 years. Remember that inverse kappa opioid receptor agonist effect, it reduces addictive potential. And this is really important in people who need to be on opioids for long term. Buprenorphine is also the safest pick in patients who are already at high risk of respiratory depression, given that ceiling effect on respiratory depression. Buprenorphine is also the safest opioid for chronic use in an older adult because it has lower risk of falls, less sedation, and less cognitive impairment. Older adults commonly have impaired renal function. Thus, all opioids except buprenorphine need longer time intervals, reduced doses, and closer monitoring of creatinine clearance. Buprenorphine is primarily excreted in the feces, and therefore it's safe for use in mild to moderate renal impairment. End-stage pulmonary disease patients are already at risk of constipation because they're less mobile. And so again, buprenorphine is attractive because it causes less constipation, because it has less binding to the gastrointestinal mu-opioid receptors and also has less of that beta-arrestin signaling. Some additional benefits. 5 micrograms of transdermal buprenorphine, if you remember that screenshot, is equivalent to approximately 12 milligrams of morphine, and that is that sweet spot that studies recommended for morphine doses for dyspnea, between 10 and 30 milligrams of morphine a day. Transdermal patches also provide more consistent and continuous symptom control than the short-acting opioids. This is a weekly patch. You change it weekly. It can help with medication adherence and also reduce pill burden. Our end-stage pulmonary disease patients are also often on a lot of other sedating medicines like gabapentinoids or antidepressants or even sleep aids that are already associated with hyperventilation. So we really want to pick the least sedating opioid possible. In addition, chronic pain is very prevalent in end-stage pulmonary disease patients, with up to 54% of COPD patients noting thoracic pain, particularly those who have a greater total lung capacity or hyperinflation in their lungs. It's not uncommon for end-stage pulmonary disease patients to suffer from depression and anxiety. The inverse kappa opioid receptor agonism can produce anxiolytic and antidepressant effects, and that can be very helpful in a dyspneic patient. onto cough. So in my own limited experience, and as was seen in that interstitial lung disease case report that I mentioned before, buprenorphine doesn't seem to work as well as traditional opioids for cough. Opioids' antitussive effects are thought to be via the mu receptors that centrally suppress the cough center in the medulla oblongata. There was a 1990 rat study, and it suggested that there was a role of kappa receptor agonists in cough. And given that buprenorphine is an inverse agonist at kappa, maybe that's why it doesn't work as well for cough. Then there was a 1995 mouse study, and they suggested that mu2 opioid receptors, but not mu1 opioid receptors, are responsible for antitussive effects. Buprenorphine exerts its antinociceptive activity via mu1, so again, maybe this explains why it doesn't work as well for cough as those that bind at mu2.
And so because mood disorder is so prevalent in palliative care, we think it deserves its own section here. Many of our patients suffer from anxiety and depression. And if a patient is on an antidepressant like SSRI or SNRI, buprenorphine is an excellent choice because unlike methadone, fentanyl, and tramadol, buprenorphine does not inhibit serotonin reuptake. Therefore, it does not contribute to risk for serotonin syndrome. Its effect on mood is secondary to it being an inverse kappa opioid receptor agonist. This same receptor can be attributed why buprenorphine reduces suicidal tendencies, reduces stress-like effect, and reduces addictive potential. Now, this is a meta-analysis published last year from the Journal of Psychiatric Research. It compared the efficacy, tolerability, and safety of buprenorphine or combinations such as buprenorphine and samidorphan versus control in improving symptoms in patients with depression. Samidorphan is an opioid antagonist structurally related to naltrexone. Personally, I have never met a patient prescribed samidorphan, but the study authors here are from VA in Vermont. Samidorphan is an opioid antagonist used in the treatment of schizophrenia and bipolar disorder, which is typically combined with olanzapine as it counteracts the weight gain associated with olanzapine. So 11 studies were included in this meta-analysis, and it did show that buprenorphine had a small effect on depressive symptoms, but it was well tolerated without evidence of abuse behavior or dependency. One study reported significant improvement in suicidal thoughts. However, it is important to note that the participants here were not palliative care patients. And so future research should clarify whether the dose relationship between buprenorphine and depression matters. All that being said, we're not trying to sell buprenorphine as an antidepressant or anxiolytic on its own. So for itching, pruritus is one of the most difficult symptoms to treat because it contributes to anxiety, to stress, and other psychosocial symptoms. This symptom does not usually respond well with antihistamine. It can only provide a mild benefit by the virtue of its sedative properties. And pruritus in liver diseases may be due to abnormal production of opioids in the liver, and some trials have shown some success with both naloxone and naltrexone. However, these drugs may cause a very unpleasant opioid withdrawal-like reaction. And so here are some case reports published from Journal of Pain and Symptom Management. One article attributed the patient's chronic severe pruritus from cutaneous T-cell lymphoma, and the patient had tried multiple medications without effect. Transdermal buprenorphine was given and symptoms dramatically improved. The patient's altered mental status and anxiety also improved. Another case is with regards to cholestatic pruritus, which is thought to be mediated by endogenous opioids, and symptom improved after buprenorphine was also started. It can potentially be an antipruritic agent, however, further studies are again warranted. And here is another area that we think show promise with buprenorphine. We hope someone listening to this talk might consider doing some more large studies based on today's discussion, and that is buprenorphine for neuropathic pain. Neuropathic pain is one of the most frequent symptoms in AIDS patients, and treatment is usually a combination of opioids, tricyclic antidepressants, and antiepileptics. So this was a study that looked at buprenorphine and fentanyl for the treatment of chronic peripheral neuropathy in AIDS patients. Their pain was assessed using the Neuropathic Pain Scale. Both treatment groups showed statistically significant reductions in neuropathic pain, including burning, stabbing, and shooting pain, and also overall pain intensity and allodynia. There was also improvement in Karnofsky performance status. However, this study only engaged 40 patients with AIDS, and so more research is definitely warranted. Now, multiple case reports have been published about neuropathic pain with regard to buprenorphine use. One of them mentions how escalating doses of oral opioids for central pain syndrome in a patient with peripheral sensory motor neuropathy resulted to cognitive impairment. Hence, opioid rotation to transdermal fentanyl and later on to transdermal buprenorphine showed pain reduction and improved quality of life. Buprenorphine interacts with different G proteins than potent mu agonists. Hence, it is not cross-tolerant to standard opioids. In general, buprenorphine blocks central sensitization or hyperalgesia that is commonly found with neuropathic pain. And our previous slides have already showed about buprenorphine's role in reducing hyperalgesia secondary to central sensitization through the kappa and delta antagonism and the opioid receptor like 1 receptor.
So the other population we think deserves their own slide is the older adult. As I mentioned with my end-stage pulmonary disease patients who are typically older, these patients tend to have impaired renal function and possibly hepatic impairment. Again, lower risk of falls, less sedation, and cognitive impairment are advantages in the elderly. Immunosuppression might be exacerbated by traditional opioids, in particular morphine and fentanyl. However, buprenorphine has not been observed to have any immunosuppressive effects. In elderly patients, they're already at risk of immunosenescence. This can be exacerbated by infectious diseases, by cancer, autoimmune diseases. So buprenorphine should be considered as a first-line opioid in the older adult. And this is actually the result of an international expert panel consensus paper for chronic pain, and we reference it at the bottom of this slide. Some final considerations is that buprenorphine is a good option for patients who have a history of alcohol and substance use disorder. We talked about potential benefits for neuropathy, but I'm also going to add chronic pain as its own special population. Think about the thoracic pain in my pulmonary disease patients. Transdermal buprenorphine and the buccal films carry FDA approval for chronic pain. Sublingual buprenorphine does not, but functionally it works the same. Compared to methadone, buprenorphine has less effect on QTc prolongation. Also, unlike methadone, buprenorphine can be titrated to a stable dose within days as opposed to weeks to months. Now we're going to move on to some warnings. If you are thinking about using buprenorphine, be aware that sublingual administration can result in tooth decay, cavities, loss of teeth, and oral infections, even if your patient has absolutely no prior dental issues. If you have access to the transdermal patches, this isn't something you have to worry about. Also, watch out for cannabis. Cannabis can increase serum buprenorphine levels, likely due to inhibition of CYP3A4. So if your patient is a heavy cannabis user and then they stop cannabis, they might experience withdrawal symptoms. Or if they become a new cannabis user, they might run the risk of intoxication. Location, location, location. Just like fentanyl patches, patients should be cautioned that they need to rotate the site of application of the transdermal patch every week, or they can run the risk of increased absorption if they continue to apply it to the same site. They should also be told that they should not apply a heating pad directly over the patch. Finishing up our warnings, while it is safe to use in mild to moderate hepatic impairment, a combination of buprenorphine plus naloxone should be avoided in severe hepatic impairment because of the increased naloxone concentrations, but you could just use the bup on its own in that patient. Also, buprenorphine overdoses require high-dose, continuous IV naloxone, and therefore you can't treat these at home with nasal naloxone. So you should counsel the caregivers that once they have called 911, immediately after they should call 911 immediately after giving the nasal naloxone at home. Our conclusions before our discussion is that we hope we have confirmed and expanded your beliefs that buprenorphine can play a pivotal role in palliative care. In particular, that buprenorphine offers unique benefits and safety profiles to our patients, that transdermal low-dose buprenorphine appears to be safe and effective to treat dyspnea in COPD, to consider buprenorphine for treatment of dyspnea with concomitant rhinorrhea, and that the ceiling effect on respiratory depression exists, but not for pain. And we hope in the future there'll be some beautiful prospective and randomized control trials. So maybe we can find out questions. Oh, there are 5 things in the chat.
Wonderful presentation. Thank you so much. We have a few minutes for questions. There's a couple in the chat that I'll start to address, but if anyone has any questions, they want to raise their hand or throw them in the chat. I have a few questions from our pharmacist, Peter Stussy. I'm assuming, Peter, your first question was answered, but please speak up if it wasn't. But the second one I'll go to first. US FDA labeling does not suggest going over 20 micrograms per hour patch due to QT prolongation. Other international labeling goes much higher. Do you use higher dosing in your practice?
So we were actually just talking about this before the presentation started. So I asked that question as well, because it's, the natural question. Why is everybody in Europe doing it and why are we not doing it? And I was told that it is not approved here, so legally not covered to do that. But what I have done is once I'm getting up to those higher doses on the patch, I'm going to switch over to the sublingual version. And I have really used a lot of the low dose patch, and that case series that I didn't get to describe with the 7 patients. After this, that's the next thing on my list, to write that up and publish that so that people can see that. But I've done it in more than 7 patients. It was just 7 patients we presented on. But Ivy, did you want to say anything about that?
Yeah, I have not seen patches that are over the limit of the FDA approval in my practice. And sometimes, like if it is for pain, then we may think about, converting to other long-acting opioid, because the max that we can go for buprenorphine is 20 microgram per hour.
I do want to add one. Nobody asked this question, but I'm going to say it myself. So one of the things that I ran into, so I was switching when I needed to get above 20 for the patch, and I wanted to switch to the sublingual tablet that you have to cut in half. So if you think back, Mary, can you go back to the conversion table? So if you think back to the conversion table, after you get above the 20, you want to take the 2 milligram tablet and cut it in half. And this patient of mine, I sent him to a nursing home, and the nursing home refused to cut it. And so fortunately, they let the family, I sent the patient, at the VA, we can even prescribe pill cutters. So I sent the family a pill cutter, and they cut in half all of his tablets and took them to the nursing home, and they did give it. So that's something to think about if your patient is inpatient, like will your hospital let you cut those sublingual tablets in half?
Interesting. My question was going to be, in your practice, do you ever find that you get a less resistance from using buprenorphine for non-pain indications? Is there less stigma that you've noticed? But the fact that you just shared that story tells me maybe not. If you get more buy-in using it for the
VA, they are encouraging us to use buprenorphine because of the safety profile. And I mean, we don't do chronic pain, but in particular, the push for chronic pain. So it's really available. I think people understand it. And our patients are actually getting afraid of opioids. So I have found this has been helpful to say, this is not your traditional opioid. This is the cousin of an opioid. This is explaining a little bit how it is safer for them. And I haven't seen people resistant. And I think having this option to be able to treat the pain and the dyspnea with the patch. Like I have a patient, and he told me in the case series, he said, I'm taking 15 pills. I am not taking another one. I refuse another pill. So if you got something that's not a pill, I'll do it. And so he accepted the patch.
Do you have any favorite resource guide for management of patients on OUD doses actually dying with days or less to live, struggling to handle their sublingual tablets?
So I have not had that experience, but I run an outpatient clinic, so I haven't seen that yet. But I wonder if the buccal patch, I mean, we have that here too. So I wonder if you could just switch over to using that, if that would be easier to tolerate. Um, those ones are actually the most expensive. So those took us the longest to get on our formulary, but we have them now. You can cut those too.
Okay. Have you ever had to switch from Suboxone to methadone? I'm assuming what was your experience with that or any advice regarding that?
I have not done it yet. I will say I have to give a shout out. So when I first got interested in using buprenorphine in 2017 because I was having patients from the substance dependence clinic come and see me on it. So I took the course before we had to do the waiver just to learn about it. But it was only about 2 to 3 years ago that I started using it in my own personal practice. And the people on this practical guide, Dr. Amy Case and Dr. Justin Kellgren, and also Dr. Katrina Nichols, was so helpful to me, and I would reach out to them with questions. So I think if I have to go from Suboxone to methadone, which I haven't done yet, maybe I would ask them for advice. And I know that there is an AHPM SIG that's that's like a substance dependence one that Dr. Nichols runs, and they also have the MAP-IT, which is also for people kind of like an addiction focus, but they have a lot more experience with this than I think I do. So I'm still learning along with you, but you just kind of jump in there and do it. So in my clinic, I'm using a lot of patches because for the COPDers, and then I have tried the buccal patches as well, and I've tried the sublingual that you cut in half. And the reason those are bad for your teeth is that it's because they're very acidic. I don't know if I mentioned that. So the ones that we have that are buprenorphine alone are the buccals, and then the combos are the sublinguals.
Um, Andrea is asking about patients on Butrans, they transition to hospice, and then hospice won't cover that medication. Any thoughts, and how do you work through that?
I would tell the hospice that they should go on GoodRx. I don't know if they can do that. I looked last week, so we're at the VA, so we are so fortunate that we can prescribe what we think is right and safest for the patient. And it was only when Dr. Poon brought to our attention how expensive it was, and then I looked on GoodRx. They were running a sale, a special, and it was $50 for 4 patches, which is a month's worth, which compared to some other medicines is not like the worst in the world. But um, I would question to that hospice why they're moving a stable patient off of that medication and see if they can get it added to their formulary, especially as we think they're going to be seeing more and more patients on this drug.
Andrea is also, and then we'll get to Max's question. Do you use buprenorphine only tablets or buprenorphine with Suboxone?
So we have the Suboxone on our formulary here because they were actually first because they were in the substance dependence treatment program, and then the Bup on its own is the buccal film.
Okay. And then finally, Max asks if if you have someone on Suboxone and pain is not improving, is there a maximum dose that you've tried to achieve to help to better analgesia, or would you rotate at that point? At what point would you rotate, I guess, is probably a better way to phrase that.
Um, I, Ivy, I'm going to let you answer as well, but the doses that we use in palliative care are so much smaller than the doses that they use in the substance dependence treatment program. So you can see on that list, the sublingual 2 milligrams TID is an equivalent of 300 milligrams of oral morphine equivalent. If you see the people in the substance dependence program, they're on massive doses, like 8 TID. So I don't know for us if there's going to be a limit, but I think I would. I haven't yet because I guess still early days. I haven't yet rotated to something else, but have you, Ivy? I would be considering other things. I have had patients who've had weird responses. One person told me thought they had edema from the buprenorphine, which I've never seen reported anywhere. So I've rotated people away from it, but usually it's because they just didn't care for it, I suppose. Said it didn't work.
I want to thank you all for being here and thank you to our three presenters for this wonderful information. Um, and everyone have a wonderful day.
Thanks for having us.
Thank you.
Bye, guys.
Bye.
Take care.